I am very pleased to introduce my good friend Karl Pillemer, Professor of Sociology, Associate Dean of the College of Human Ecology, and a good friend of mine after all these years. He's a person I admire more than anybody else, actually. Well, after my mother, who was a great cook. But so Karl. He's a great cook. Karl is an expert in sociology of the family, sociology of aging in the life course, and social problems afflicting older people. And I think maybe the three best things I can say is that Karl always does something exciting and interesting. That's one of the reasons why he's one of the people I admire the most. And everything he does, he designs so that it's relevant to real life and applicable to real world problems. That's my greatest compliment. And the third thing is, I think, given the topic of this presentation will be no exception. I'm prepared for a really interesting and informative presentation from Karl.
Well, thanks, Elaine. I admire you too. Well, thanks everybody. And you know, we sort now. I do have a little tendency to lose my voice, but I presume everybody can hear from me. You know, I just wanted to ask first, I don't know, I'd heard that there might be some folks either coming from local long-term care facilities. Is anybody here who's from where are you folks from? Longview? Longview. Also Longview. Anybody else from the actual real world? How you doing? Yeah. So where are you from? Office for the Aging. Oh, great, thanks. Well, it's wonderful to have you here, and I look forward to your feedback on this study, because you're probably more aware of it than we are. In fact, we're actually trying to replicate this project in assisted living, so places like Longview, so that is one of our next thoughts. And it's wonderful to be able to talk to everybody here, and thanks to everyone for coming. I know it's not the most cheerful topic in the world, but it's one that we think is really important and have worked on now for about 6 years. I know, you know, the font is small, and I'm going to talk through most of these slides. If you're nearsighted like I am, there are a couple chairs also up front. And one thing I'm going to do today in the 40-ish minutes I have to talk to you, I'm going to spend a little bit more time than might be usual on methods, because actually a significant amount of the funding, especially from the National Institute of Justice, which partly funded this, was to develop a way to measure and to conceptualize and to think about this concept of resident-to-resident elder mistreatment. So I know it's going to be after lunch, and I don't want to stupefy you with methods, but I also would like your feedback on them. Also, this is the dry run of these findings. After many years, we finally have these prevalence findings, and there's going to be a little press conference at our national meeting a week or two from now. So I'd be interested to know if anything really seems like wrong to you. So this is kind of work in progress, hot off the presses, and would really like your feedback on it. Well, over the last couple of decades, there's been increasing attention to the problem of violence against older people, and more generally of mistreatment of older people. People talked about, you know, the 1960s as the decade of the discovery of child abuse, in the 1970s as the decade of the discovery of the abuse of women, and the 80s and beyond, really, people turned their attention to elder mistreatment. And there has been a steadily growing literature on elder abuse in the community, so in people's homes and home situations. And that actually now has basically hundreds of articles, and it's really been demonstrated to be a highly prevalent and highly injurious phenomenon. But people haven't thought that much about long-term care facilities and possible mistreatment as much as they have in community settings. Now, it might surprise you, so I want to start with kind of a dramatic statement. And let me give a disclaimer. I've spent my whole career working with nursing homes, and some of the best people I know work in them, and I think they do the most meaningful work on the planet. So there's nothing I'm going to say that is meant to blame or be negative about people providing care in nursing homes. But there is an important fact about them which is really surprising. And that is that this setting, in which the most frail and vulnerable people in our society are cared for, is also an extremely violent institution. so that the research shows that if you start with looking at violence from resident towards staff, it's a very significant cause of workplace injury. Almost all staff experience either verbal or physical altercations with residents, often every day, sometimes multiple times a day. And other studies, including some I and my colleagues have done, have found that a surprisingly large number of staff in nursing homes either say that they have observed staff behaving towards residents in ways that they later regret, either using either verbal or even physical aggression, and many more say they have observed it. So that, indeed, probably the only institutions in which some base rate level of violence or of conflict and verbal aggression and physical aggression are so common are prisons and mental hospitals. So this is something that's not isolated, it's woven into the fabric of nursing home life, and I think you'll see why in a bit. But despite this interest, though, almost no attention has been paid to a potentially very prevalent and possibly very injurious behavior in nursing homes, and that is aggression, violence, or mistreatment perpetrated by residents on other residents. And I know there are folks here who've looked at this in residential child care, for example. I think you'll see some of the same themes and ideas emerging. And we refer to this as Resident-to-Resident Elder Mistreatment. And to keep from saying that over and over, I'll say R-REM. And I'm going to describe these three interlocking studies. It's mostly the National Institute on Aging study who funded this large-scale prevalence study. And as I say, it really was an extraordinarily time-consuming project, lasting actually over 6 years until we had the real data, and again, I think you'll see why. Okay, let's see, this is going to work, because I'm cursed when it comes to electronic devices, so like if this explodes, it's my fault. I'll be going through these, so if you can't read them, it's not a huge deal. But what's happened, though, is in recent years, at least the media and the public, to some extent, have become interested in this notion of resident-to-resident elder mistreatment. If you talk to anybody, if you have friends who work in nursing homes, it's one thing that people talk about, so staff and clinicians who work in nursing homes often complain about it, but the media have also paid attention. And so there have been highly publicized newspaper articles on the presence, for example, of registered sex offenders in nursing homes, of whom there is a population. There also has been media reports about younger and potentially violent psychiatric patients who have no physical disability but are placed in nursing homes because of deinstitutionalization. But what especially gets publicized, and there have been all too many of these, are dramatic, either very severe violence or homicide. And this was a case in Massachusetts that actually just got resolved, although it happened a few cases ago. This was a person, it was the oldest person ever tried for murder in Massachusetts. So she was eventually adjudicated as incompetent to stand trial, but a 98-year-old a resident of a nursing home strangled and suffocated her roommate, who was 100 years old. Those kinds of cases get highly publicized. But there haven't been any studies yet that have directly observed or directly measured this phenomenon of resident-to-resident elder mistreatment. So how R-REM occurs, in day-to-day nursing home life isn't known. And moreover, beyond confirmation from multiple sources, which I'll touch on in a minute, that this kind of resident-to-resident elder mistreatment exists, we lack any real prevalence data about it, so how extensive it is, which is what we need to know, right, in order to know how important a problem it is, or the attributes of residents or the environment that might contribute to it. However, there is preliminary evidence, and some of which I've shared with you, that it's probably prevalent and definitely understudied. So there's a preliminary evidence that it is an extensive and harmful problem in nursing homes. One indirect piece of evidence is there's been a lot of research on problem behaviors of residents, disruptive behaviors or other kinds of difficult behaviors. And I'll come back to that later, but many residents do engage in agitated and aggressive behaviors. As part of the research that we conducted at the beginning of this project, we did focus group studies in 16 nursing homes, and staff, almost all staff too, had witnessed this problem of resident-to-resident elder mistreatment, beyond kind of general obstreperousness. Most staff had witnessed the problem and been involved in it, and most of them simply did not feel equipped in ways of dealing with it. So it's a source of great frustration, helplessness, and powerlessness for staff. The consequences on victims haven't been established, but evidence suggests that they may be very severe. There's only been one study that looked at the possible effects of R-REM, and that was by Shinoda Tagawa and colleagues, and they looked at injuries that were sustained from another nursing home resident during one calendar year. And these were cases that were reported to a statewide incident reporting system. Of the 294 incidents reported, they found lacerations, bruises, fractures, and the majority of residents were actually hurt in the face or the head. And given how frail people are, even if it's not a very serious altercation, it can have extremely serious consequences. Also, if we can extrapolate from other evidence on elder abuse more generally, it clearly has serious emotional and psychological consequences. And in studies that my colleagues and I did a while ago, in a long-term longitudinal study, if you've been a victim of elder mistreatment in the community, you're more likely to die over the study period. So there's increased mortality as a result for older people. And really the evidence suggests that it may be, it's certainly probably morbid and quite possibly increases mortality risk. And it's not just that, and the folks who work in long-term care or have worked in long-term care know this better than anybody. Dealing with this issue is really hard for staff. It causes stress and burnout, and again, this sort of feeling of helplessness. Staff intervening in violent interactions can be injured themselves, and that happens. And it's damaging to the facilities themselves, who are actively and continually trying to avoid lawsuits. And I've served as an expert witness in some court cases, and resident-to-resident elder mistreatment is a common reason why long-term care facilities experience very expensive lawsuits. And also state and federal regulators certainly frown on it. So the issue is that despite this whole scenario, that even though we haven't had firm prevalence figures, we certainly know it goes on, and you only have to talk to a certified nursing assistant in a nursing home for 2 minutes and they would tell you about it. There aren't any treatments or interventions for it. There are some more generalized treatment programs or intervention programs for residents who engage in aggressive or problem behaviors more generally, but there's no attention specifically to resident-to-resident altercations or aggression. And the only regulatory help, so to speak, people have is that you have to report it, or at least the most egregious cases. Other than that, our regulatory system, there's very little guidance for how people ought to recognize it or how they ought to respond to it. Finally, just while I'm complete telling you what we don't know, is we really don't know much about what causes it. There's very little evidence about the possible causes of resident-to-resident aggression. Undoubtedly, the clinical characteristics of a nursing home predispose people, as I noted, towards these kinds of behaviors. You have a population that is that at least 3/4 have some form of cognitive impairment, probably around half are pretty severely demented, and of those, around 40 to 60% exhibit agitated behaviors, and sometimes for a long period of time. When you concentrate people like that in relatively small spaces, it's you could certainly imagine that these are all factors, because these kinds of demanding illnesses reduce your inhibitions, among other things. Environmental and organizational factors are also probably quite likely. Living in a special care unit for dementia, although that has some positive aspects, is probably likely, again, to increase your risk. Staff-to-resident ratios might as well, crowding. So one possibly hopeful aspect is if we could uncover environmental problems and solutions. So although all of these studies have been important in demonstrating the existence of R-REM and giving us maybe a few ideas for causes and intervention. Each of these studies use small and unrepresentative samples, very, very narrow methods of identifying R-REM. And further, they often rely on just on staff identification or on records reviews. So those of you who aren't in the nursing home world won't be aware that there's something, there is a minimum data set called the MDS, which people have to repeatedly acquire data on residents. But that's often unsystematic. There are often differences, and I'll come back to that in a moment. But those kind of data aren't ever ideal for researching this kind of a phenomenon. So here are the fundamental assumptions or sort of aims of the study. We wanted to get a better understanding of the extent and correlates of resident-to-resident elder mistreatment in nursing homes. And the goal was to use a triangulation of multiple methods to try to uncover all. Now, of course, you can never uncover all, but as many incidents of R-REM over a 2-week period on all the study units in nursing homes. And these methods, which I'll go into a bit of detail on, allowed a broad range of R-REM incidents to be detected and analyzed and verified, giving a more detailed portrait of this phenomenon than has ever been available. We also, as I said, wanted to identify risk factors, and then with extra funding from the Department of Justice and a Department of Health grant, that we were able to look at potential interventions. I probably won't have time today to go very far at all into the intervention work. If folks have questions, be glad to answer it, or that could be my talk at 12 next year. Just something for all of you to look forward to. I want to say a word about the definition. We actually worked long and hard on the definition because it's difficult to define. We empaneled a group of 5 experts, had them look at existing definitions and work with us to come up with one. So for those of you who can't see it, we define R-REM as negative physical or sexual or verbal interactions between long-term care residents that, one, in a community setting that would likely be construed as unwelcome, and 2, have high potential to cause psychological or physical distress in the recipient. And those 2 things are important because, remember, this is something that we assume from everything we knew is a very high base rate phenomenon, that things like this occur a lot. So we actually wanted to have a more conservative definition. One thing is that something in a community setting that would be seen as negative. So it's possible, for example, that staff in a nursing home get used to someone who's trying to get through a crowd of people and rams into them with a wheelchair, causing harm to someone. At home, you would think that was unusual, and you would try to do something about it. So the idea is to use the kind of standards that we use outside of nursing homes in a way to adjudicate if something is mistreatment. And the second is that because, again, this happens frequently enough, is to really focus on events or episodes that might have negative consequences for people. There are a couple of other things that we said about it. It has to be aggression directed towards someone. So someone just yelling in a hallway, screaming out things, that wouldn't count. There has to be, like, it's an interactional situation. And, the recipient may not be aware necessarily that this has been done to them, but it still counts in that sense. Now, I want to say a word, you wonder, can you really study this phenomenon? And one of our biggest worries in applying for a big grant on this was, would people say, this is simply too difficult to study? You just won't be able to do it. And we've been told that before on other studies, so we tried not to believe that. Several reasons is, you can't do, if I told you the first reviews on our big community study of elder abuse and whether people would tell you if they've been victims of elder abuse, and they really do, by the way. So, you might think, well, let's use the official systems of reporting. Let's use agency records and facility records. However, those are really subject to underreporting of cases and non-standard or inconsistent reporting policies. If you want to ask residents about their own mistreatment, I told you about the high burden of dementing illness And if you add to that problems hearing, problems seeing, and so forth, you'd have trouble basing a study entirely on resident reports. And some residents will have incentives not to be truthful. You know, they may be worried if they complain about something like this, that there would be retaliation. So that's a problem. And staff informants may not see it because they avoid aggressive residents. They may be targets of aggression themselves, leading them to over-report it, and of course, that these situations are likely to occur when staff aren't there to observe it. So that those are all problems. Also, the issue that we talked about before is staff become used to this kind of behavior, but they become accustomed to a lot of R-REM and don't see it as noteworthy or as actionable. If you just do researchers observing, that affects, you know, the environment, so just doing an observational study. Although a colleague of ours from Carnegie Mellon, who we did a paper with, was involved in a different study where a nursing home allowed 24/7 video coverage of all its common areas. If we had more time, I'd show you an R-REM incident from there. I mean, that would be one way to go, but then you miss all private spaces. And it's very difficult, obviously, to get people to ever agree to that. There are issues of getting into facilities, you know, because they're worried about their reputational risk, and they have an incentive to either avoid or to minimize R-REM. But I will say we had very good cooperation from facilities, and let me tell you a bit about the methods, and then I'll share some of the results, and then we'll be done. So we did this in 10 nursing homes, and it was impossible to do any more because, as you'll see, the data collection is so extraordinarily labor-intensive. These were drawn from the entire population in New York City and Westchester County of homes with more than 250 beds, because again, for the efficiencies of scale, you know, going to a lot of different smaller nursing homes was difficult. To shed light on generalizability, that we compared quality indicators and survey results and other features of these 10 nursing homes to both state and national averages, and they're quite comparable, of nursing homes of that size. So, you know, we think that this is generalizable, or at least we can't quite think of why it wouldn't be generalizable. And a total of 2,011 residents were assessed. And you'll see in a moment, when I say assessed, I don't mean like a little pencil and paper thing. So between 1 and 2 hours had to be spent first with each resident, followed by interviews with all the staff who care for them, reporting on them. Then a forensic review almost of records around them, and other data collection. So it's very time consuming, including observational measures. One of the big things that we did in this study was create the resident to, no, I think I already talked to you about it. It's hard to keep track when you can't see your slides right in front of you. We created something called the R-REMI. Now, that's not a very creative acronym, is it? The Resident-to-Resident Elder Mistreatment Instrument. And data using this instrument that were collected from residents and staff. And you'll see it was used also for observation. But all residents who were capable of being interviewed were administered this instrument that was specially created for the study. And you may ask how many can answer it? And the answer is way more than you think. There have been a number of recent studies showing that even pretty severely demented residents can at least answer fairly simple yes or no questions. So that one of the philosophies of folks doing the work I do now is to really try to interview residents, you know, despite cognitive impairment, you know, to make sure their voice is represented. And so residents were asked about their experience of R-REM over a 2-week period, and you can't really see that, but that's what it looked like. All certified nursing assistants then on the study units were administered a staff version where they talked about each resident. So, pardon my point, we know, but like Mr. B here, has he been involved in this? Ms. W, has she ever had any of these things happen to her? And so that was triangulated there. I want to say a word, this R-REMI was created by taking an established instrument called the Cohen-Mansfield Agitation Inventory and merging it with family violence research methodology. So for those of you who work in that area, you know the famous conflict tactics scale devised by Murray Strauss. But we use those kinds of numerical categories for quantifying how often something happened with this agitation index. So we selected the items on that index which seemed like they were R-REM, and then we conducted a series of focus groups with staff where they helped us to refine them. Then these were then gone over again by senior project staff. They were cognitively tested. So really the first year of the study was simply developing the instrument. And staff were incredibly helpful. So for example, as we showed them our items, staff said, you know, like, you're missing one thing which really causes this. And they led us to insert a category of inappropriate caregiving. Where somebody who may have cared for their husband 40 or 50 years before sees someone else who needs help and starts to try to change their diaper or fix their hair. And that led to a surprising number of altercations, these well-meaning attempts to provide care for somebody because of dementia that, you know, really were, in fact, inappropriate and led to aggression. Briefly, like, so there are two versions. So we asked staff about, like, resident X, and we asked the resident, him or herself. We also, so there were 22 items in total, all focused on the preceding 2 weeks. If it was a resident, we asked about the place and the time of day it occurred, and the gender and relationship of the perpetrator, or we collected that. Otherwise, staff reported what actions they took. And then actually residents this is something else which our staff encouraged us to do. They asked us, and we included a 1 to 5 rating of how disturbed the resident was by this. So if it was a minor episode of a little kind of argument, perhaps they weren't disturbed at all. I'm not going to share those data in this talk. But these are some of the items. If you can't see them, I'll say there were 4 main categories. So but there was verbal, cursing, intimidation, ethnic slurs, the physical, like hitting, kicking, or scratching, the sexual, saying sexual things, or inappropriate touching between residents, and other. And the other category is things like unwanted help I just described, rummaging through someone's belongings, invasively entering their room when they didn't want you to, those kinds of things. And finally, there was one other thing we did that it's hard to get too excited about little methodological advances, but this was really fun. The question was, how could we collect these incidents in real time? And you folks working in long-term care, I wonder if you think that you could possibly stand to do this, but we created something called a shift coupon. Jen, you from nursing or others may have heard of this, but for unwarranted events or unwanted events, one way people try to prevent them is give people the equivalent of a prescription pad. So like one way it was developed was for needle sticks, for example, and as soon as this event happens, the staff person pulls out this pad and checks off the event in maybe 1 or 2 minutes and puts it in the box. So as each day was going on during this 2-week period, staff on all shifts were recording every event they saw. Plus, we also had research assistants in the facility, and if they saw something, they could add it. So it looks like this. You would describe the incident. You would put names and dates of people involved. Then these are the abuse indicators I just read to you. And then a little bit of context, so someone could say, where did it happen? And then we had, from our focus group, so what the main causes were that we knew about: competing for the attention of staff, resident A is yelling out noisily and resident B tries to get them to stop, those kind of things, and then what the staff person did. So those are data that hopefully an army of graduate students over the next 5 years will happily analyze for us. We haven't had time to look at them yet. Then finally, as if, I want you to, both feel sorry and admire us. Yes, so that's what I want. That's what I want. Then the team met as a group over the course of years and investigated and adjudicated every single positive case. An interviewer went back, talked to people involved if possible, looked at the records, and then a group consisting of a geriatrician, nurses, CNAs, researchers, adjudicated each case. And those are what the prevalence rates are based on. And so we have these event logs. useful both for qualitative and quantitative information. Now, so one question is, how much R-REM is there? Prevalence figures rarely, ever speak for themselves. You have to interpret them in a context as to what they are. And, it's sometimes hard to tell, like whether they're high or low. For example, elder abuse as it occurs in the community hovers between sort of 2 and 4% of older people have experienced it, which seems pretty high, actually, to me. But so you have to think about it as to what's high and what's low. I do want to say, actually, one other thing about prevalence that's really critical. This is not the prevalence of victims. So this is the prevalence of being involved in an R-REM incident. And the major reason for that is, as you'll see when I give you a description or two, it's really hard to tell a victim from perpetrator. We actually tried to collect that information, and we're going to analyze that in a future paper. But so often, by the time anyone's aware of it, it's like an altercation, and you really can't identify who's done what to whom. And so this is the prevalence, at least for now, of being involved in the past 2 weeks in an R-REM incident. So it's basically 20% of residents over a 2-week period. So 1/5 came up as R-REM positive. And if you think of that as a probable underestimate, because we couldn't catch everything, to me it seems pretty dang high. And in terms of a physical altercation, which really may be the most damaging, about 6% of residents had been involved in a physical altercation, and about 16%. And these aren't mutually exclusive. This is you could have had more than one. So our number of about 20% is the pure number, but these are people who could have had more than one type. Close to around 16%. Now, to get an idea of what this looks like, here's one of the incidents, that would have come up as verbal and physical positive. The setting was 20 residents are sitting in a sort of lounge area that also serves as a dining room, and they're watching TV. Resident J was screaming from her wheelchair over and over, "Ow, ow, ow, ow." And you can imagine that gets tiresome if you are hearing that for an hour. Then as Resident R came over to get her to stop, Resident J hit his hand. R said stop, and J said go to hell, and R replied, no, you go to hell. A CNA tried to separate them and was succeeding, but then somebody wandered out of the room who had to be kept an eye on, and the CNA left. J then hit R again. R kicked J, and J grabbed R's leg painfully. And so that's the kind of incidents that we recorded. For sexual R-REM, it was 1.3%. That was very often sort of lewd gestures or lewd language from men to women, also crawling in bed with someone, mistaking someone. And one man kept on referring to a woman as his wife and was, confused why anyone was stopping him from trying to cozy up to his wife, even though she was a stranger. It happens to me some. No, that's the other R-REM, which was around between 10 and 11%. So one example, a man awoke to find someone rummaging through his drawers. He yelled at the man. The person grabbed some of his stuff and ran out of the room, and he was very disturbed by it. The final thing I want to talk to you about, I guess we're doing okay time-wise. Am I talking really fast? So who's most likely to be involved in an R-REM event? And one key feature of this study is we're trying to merge the use of quantitative and qualitative data. So the first slide I'll show you is from a logistic regression of looking at overall R-REM. And I was also interested specifically in physical R-REM because I think it may be the most immediately damaging, and the risk factors are almost identical. So it's an interesting profile. If you can't see that, I'll say the first four all sort of go together. People who are most likely to be involved in incidents are younger, less cognitively impaired, less physically impaired, and display more disturbing behaviors. And what that really is, we haven't done all the tests for it, but it's fundamentally a U-shaped curve. If you are not demented at all, or if you're extremely demented, so you can't do very much, you aren't likely to be in these situations. But your typical, the frequent flyer, so to speak, as one of the staff called them, who is involved in a lot of these incidents is a younger person, and we actually found no gender differences. Other studies found men more than women, but in our case, there was no difference by gender. It's a younger, relatively physically able, mildly or moderately cognitively impaired person who displays disturbing behaviors. And they are by far the most likely. If you live in a dementia special care unit, you're at way more risk of being involved in R-REM. And that's despite, by the way, there are many good things about being in a special care unit, but this is a bad thing. And one anomalous finding, these are New York City area nursing homes, and so they have a fairly significant black population in them, even though African Americans typically make up a small percentage of nursing home residents. And being black was a major protective factor. White residents were at a much greater risk. We have actually no explanation for that except for one highly, highly speculative one that actually some of the staff who worked there gave us as a possibility, namely that in New York City area nursing homes, a lot of the staff are African American. So that there were a couple people who thought, that maybe the cultural congruency between staff caring for them and residents themselves might serve as kind of a protective factor. But so we're trying to see, it was a very strong, a much lower odds ratio of being in one of these incidents if you were African American. But we're still trying to figure that out. Now, so in addition to this, but this gives you kind of a profile, but we really wanted to look at this in much more detail and to use our qualitative and narrative data. So I told you that there were very detailed event reconstructions on every event, as clearly detailed as they could possibly be. And so again, with the help of eager and willing graduate students, but we were able to go through all these events, carefully code them, and develop categories of them. And I think these are kind of instructive. There were 6 categories from this event reconstruction study that are in some ways consistent with the quantitative findings. And one of the main, kind of gestalts or sort of kind of settings or types of events was invasion of privacy or personal integrity. Privacy is at a premium in a nursing home, and it's difficult to maintain your personal integrity. So a lot of these incidents come from someone simply coming too close, invading someone's space, doing this inappropriate caregiving, trying to push someone somewhere that they don't want to go. That was a typical scenario. A second body of incidents are from crowding and collisions and congestion. Many of them involve people in walkers or wheelchairs in an elevator, crowding around an elevator, trying to get through other people, and injuring somebody as a part of doing that. So crowding in the close proximity. A third, overarching type is roommate issues. If we could give everybody in a nursing home their own room, as some places are now trying to do, and they do actually do this in Scandinavia, you would reduce a whole bunch of R-REM, because a lot of these are, if your roommate is, has dementia and is disinhibited, it leads to a lot of these problems. We also had to have a category of simply unprovoked events. And I myself have experienced those. I was doing research in a nursing home not too long ago, and I walked by somebody in a wheelchair and they hit me. I actually said, I don't even work here. So that people do, there were incidents in our study, person A sitting next to person B at the dining room and stabs him in the arm with their fork without provocation. Or 2 people were, for example, having a conventional normal conversation, and person C says, will you just shut up, and starts to scream at them. So, again, it's either a threats experience that people can't perceive, or it's part of brain disease. And finally, was inappropriate sexual behavior, and I've given you some ideas of that. Well, I do have time to share a word about intervention, but this is from one of the videos in the training program that we developed. The New York State Department of Health offers grants for dementia, where you can do and test intervention programs, and we were very fortunate to receive one of those. And I won't say too much about this, but the first thing that we learned, by the way, the first question is, before you do an intervention, how are staff dealing with this now? So we had a geriatrics fellow who did a very detailed focus group study asking staff for their strategies that we published. And what we really learned is, A, they feel like they are continually attempting to minimize this or deal with it or deal with the consequences. So it is multiple daily event for them. It's something they're thinking about. You know, how do I keep person X away from person Y? Also, they have very few institutional guidelines for how to deal with it. So it's not like people are intensively trained and told exactly what to do, that they really don't know what to do. And so they're in a DIY, a do-it-yourself mode, and very eager for intervention. So we created two things. One is something we called the SEARCH model, which is an acronym that stands for things you can do. And the other one was a unit on simple awareness. What is it? How do you track it? And as part of the intervention, we actually had people do these shift coupons for a while. And the goals of training were to help staff identify, cases, like know what it is and when it occurs, to be able to intervene in it better, and get them to enhance their knowledge. So it was these kind of simple ones, but also to improve some resident outcomes by preventing and managing R-REM. There were 3 modules. One introduces the topic, and then one goes through the search approach, and one talks about learning how to identify R-REM. Our videos, through some strange connection, were narrated by the late journalist Charles Osgood of the Osgood Files. He's got like one of those voice of God voices, that was very good, and that was nice. And there are expert interviews in it and that sort of thing. And then there was this search approach, and the idea is that you support, evaluate, act, report, care plan, and help to avoid. And I won't go through all these, but I'll give you an example. So under support, staff will encourage first, you support the resident until help arrives. You make sure there are no injuries. You listen to everybody involved just right there as it happens, because these people forget as to what happened, and validate the residents' fears and make sure they're safe. Evaluate is then you evaluate what actions are needed, you monitor the residents' behavior, evaluate and support other residents, because often these incidents are very disturbing to people who are around them. I won't go through the whole thing, but that gives you an idea. So it showed dramatically increased knowledge and recognition of this. But for a relatively time-limited intervention, the most exciting analyses that we have done is that on the units which had the intervention, it looks like there was a pretty strong and significant, over the time period, reduction in falls and in accidents and accident reports. So that, and these kind of incidents are obviously often reported as accidents and lead to falls. So it looks like, that there was actual improvement in resident outcomes. And the mechanisms were, we found, because we did a lot of qualitative work, increased awareness, better tracking, and this gave everybody a much more of it more was like a sensitizing exercise. So people were simply aware of it as a problem and felt empowered that they could do something about it. But this is a picture of my shop at home. So anyone who knows me knows how absolutely ridiculous that is. I want to conclude by saying that this is a case where we need an evidence-based toolkit, where it's obviously a highly prevalent problem. It causes mental and physical, damage and distress. It probably leads to extra costs for unnecessary medical care. And what we need is a sense of experimentation for how to deal with this. I think that the one good reason to do a study like this is to help staff move beyond powerlessness and a sense of acceptance of this. And that's really one thing that we hope that these prevalence findings will do. Third, I think that we really want to engage designers and people who study dementia in thinking about what kind of bricks and mortar solutions might be possible for this, since there's a whole bunch of it that seems to be environmentally engendered. Is, for example, integrating non-demented and demented patients together a better solution in terms of at least reducing this one problem? So I think that would be the next agenda. And for us, we would like to do a prevalence study in assisted living. hopeful that we'll be able to pilot some of that with Longview, because our former colleague Rhoda Medor has been so involved through IC. And we also want to continue, we did, okay, now this can be a test. We did an effectiveness trial, and now we want to do an efficacy, no,
other way around.
we did an efficacy trial. It's like it won't stay. The idea would be to streamline these assessment methods and then really do it in a large number of nursing homes in more realistic settings. And let me stop there. Would love any comments, constructive criticism, strong emotions, humorous personal anecdote? Yeah.
I have two questions. One, my background is more in domestic violence, so constantly in that field we talk about power and control. So once again, in a nursing home, for whatever reason, the residents have sort of lost their power to control their own lives, and that's why the prevalence is higher. And then two, I don't know if you have any background on the residents that were doing more of the quote-unquote physical harm, if they had previously been involved, like if you had any of their previous record of whether they were involved with physical abuse.
You know, I'll take those in reverse order, both really good questions. The one thing I have to check on that, we did, the National Institute of Justice funding allowed us to create this thing that they called a forensic chart review, where to see how much information you could get from a nursing home resident's chart. And if they've been there a long time, their charts are like this. And actually not a lot of them use electronic medical records. So some of that information may have been in there. If the person had like previous assault or previous other, and that's something which would be great to check. I think you are probably really correct around this sense of people trying to establish a zone of personal integrity, a way to stop things from being so invasive. But we aren't sure about this. It seems like noise is a factor. It's just kind of this overwhelmingly stressful environment, especially if you have dementia. If any of you have cared for a person with dementia, they love routine, a relatively quiet environment. But I think you're right, this notion of lashing out because you feel like you don't have any way to have your needs met. It's why, I should have mentioned this, I think a lot of people would agree that the best solution to this lie in what's called these personalized care approaches, where you really look at what the individual's needs are first. Are they doing this because they're in pain or because their medication needs to be changed? So a really heavy emphasis on the person themselves, and one part of that would clearly be making sure they have opportunities to express needs. But yeah, I think that would be a logical thing. Oh, sure.
Just wondering about the organizational context, and these were very large facilities.
Well, they aren't so large. Nursing homes are typically around 120 beds. So these were, probably a quarter of nursing homes are around this size. But they are larger than 3/4, so you're right.
Right. Well, I just wondered if you thought that had much influence on it.
That's a really good question. Yeah. You could argue that maybe, it's funny, I'm going to think about that, but because there's a countervailing aspect. Larger facilities sometimes have richer numbers of staff, and they're more likely to have like a psychologist on staff and psychiatric consults. On the other hand, there may be more staff turnover, less time for individualized attention. So that's a good question, and that's one thing that we could definitely test if we can get somebody to fund a study like this again. I don't know in what order people are.
Just a question. I don't remember well, but I think I read that in Europe, the tendency, some countries at least, the tendency is to have smaller nursing homes than in the United States. So it's very seldom to see 250 people in one.
That's true.
So I don't know if there is something that you can.
It's so unbelievably different in Europe. I mean, at least in Northern Europe. First of all, there's no such thing as what we have as a certified nursing assistant who get basically 75 hours of training and then are put in charge of the most vulnerable people in society. You don't actually touch a resident in Germany until you have a 2 years apprenticeship. So that people are way more training. In Scandinavia, like in Denmark, they've essentially eliminated the concept of nursing home. But you're seen as someone who has a room and services are provided to you. So some countries are dramatically changing the whole view of this, and you're right. I mean, and certainly facilities tend to be smaller. In New York City, in that area, there's also historical. These are like big, 10-story high-rises. On the other hand, if you ever get a chance to go to the Hebrew Home for the Aged, which is one of ours, it's like you would move in there right now. So that, there is a huge individual difference. But yeah, I think it really is different internationally. Who else did I? I'm sorry, him? Yes.
I was, this is off the top of my head, when you said that there was a race difference, and it was countering my intuition. I just thought about it for a moment, and so this may not have anything but first reaction kind of things. White people tend to be accustomed to being instrumental to controlling and changing what's happening in their world. Black people may have some sense that they're unable to be controlling their environment. It happens. And you roll with it, especially in mixed environments.
Right.
That's just
I think that's a very interesting hypothesis, actually. And that, you made me think of something else which will come back to me, but I think that's interesting. Thank you for that. That's great.
That's the same idea. My question is really short, having just gone through this recently with my mother. I found that just personal visits from us, from family, really tend to alleviate a lot of the boredom, loneliness, and frustration. And I even helped a lot of the nurses, and I know a couple of my friends who are now caring for aging parents are doing that same thing. They live close enough by. Do you think that's a protective factor for the residents?
Absolutely. The one
We have a caring relative show up as often as possible, kind of normalize things, have dinner with them maybe, and, take a little look off in the age.
It is such a double-edged sword because the answer is absolutely yes. The nursing home residents, been study after study, including some that we did, the more socially integrated they are, the more visits they have, the better off they are. Absolutely. There are two problems. One, a major risk factor for entering a nursing home is not having any relatives or being isolated. Because if you don't have anybody to care for you, you're much more likely to go into one. So people start out often more socially isolated. Also, unfortunately, nursing homes can tend to repel supporters. People stop liking to go there. So that often it's a vicious circle, but people really need the support. But other people find the nursing home so off-putting that they cease to become involved. Yeah, but I think that's one thing I really do hope that we actually have from the records review. And I haven't looked yet, but the degree of social support of the residents, how many external visits they have, I think really could be an important protective factor against being involved in this. It might reduce agitation too. And the resident gets better care because often, like everywhere, like Cornell, squeaky wheels tend to get the grease. And if you have relatives who are advocating for you, you often are likely to get better care. So I think that's a really good point. Was there, Jen?
Getting a handle on the sort of intervention, it strikes me that there might be two very, very distinct approaches, one for the common space into this and one for the private space that involves into this. And I just wondered if you sort of, disaggregated your data that way, looked at the, out in the common areas and the dynamics of R-REM there versus the dynamics of what probably was very much underreported in group history.
Yeah, we haven't done that, and that's another, kind of high on the paper list. I'm trying to think just, the vast majority of in-room incidents fell into two categories. Someone unwanted wandering into your room, either because they think it's their own room or because they want something in your room, and problems with roommates. Better roommate matching, which is sometimes difficult, could really be huge for people. Like often the social worker person in charge simply doesn't have time. But that would be, I think, one potential intervention, as well as these kind of environmental barriers to prevent wandering. But I think that's one thing, is to look at these different contexts. I think that, I'm sorry, I have those two hypotheses kind of, but it's something that we would definitely look at. And it's nice because we have all these units embedded in facilities which are different, so we can look at some variation in that.
You can look at the design impact on the sort of incidents of common space.
Right. That's sure. Oh, I'm sorry. Was there somebody else who I missed? You go ahead.
Okay, just in terms of transition space, I used to work in corrections, and there's a lot of protocols for transports, getting people to dining halls, or, I saw elevators popping up in areas where there's problems. And so, there were really specific protocols on how all these things could be used, how people move.
So it's like an operations research question almost, How do I get, I think that's a great question, and I even wonder if people have thought about that much of what the ways are to optimize transport of people from one place to another. But I'll tell you, I was just doing research in a very, very high-end assisted living facility, and there was a resident-to-resident altercation with people gathered around the elevator and walkers, and who was in the way and who wasn't moving. So it is. You're right, though. That's a problem that seems like it should have a solution. I mean, we put someone on the moon, or we could figure out how to transport people. Although, I'm sorry, that was going to be a digression. I'll see it this time later.
Since you spend so much time on methods, I have one small methods question. You say you're not really making a distinction between perpetrators and victims, but it's really hard to do. That means prevalence data is really incident data that involves maybe two people. So they're non-independent observations in terms of you say what percentage of people have or what's in terms of so that incident could involve two people and they would get some of the same scores on certain characteristics of what happened. So
You're right.
Way to control for the non-independence of some of that.
Right, so we're treating it as if you ask kids in the school, have you been in a fight? Right. Like without saying, did you start it or didn't you? So I would think, now help me here, so I would think in terms of individual prevalence, namely if we say the prevalence figure still holds up because 20% of you have been involved in an incident. But in terms of predictors, right, especially if you look at situational predictors of the incident, that there is going to be duplication. Yeah. So what I would really like to do is go back to the data, and we just haven't had time yet, and see if you think, I want to go back and see at least how many incidents in which it is possible to determine the perpetrator. From my reading, I think it should be at least half. So I think we ought to run everything on victims, and see if it looks the same. But I think it is it's a weakness, and we do need to think of how to overcome it methodologically. Shirley?
So does that mean you also don't have a way to track people who are involved in repeated incidents?
So this was on, yes, we do, and so we know if Mrs. Smith was involved in 1, 5, or 10 incidents. And so here's more of a confound actually. Mr. Jones is this kind of frequent disruptor who's been involved in incidents, with 8 different people. That, so it could be in some cases the same perpetrator who is getting into a lot of trouble with a lot of different people. And that's something I think which really needs to be disentangled. Yes, so but we do know how many incidents occurred to each person. And we had to exclude incidents. The reason why it's an undercount is if somebody would say, oh, Mr. Smith, he's just mean to everybody. But we couldn't consider that as an incident because there had to be an incident. But you're right. I think the duplication of perpetrator is sort of a complex issue, and people being involved in multiple incidents. I think, though, the mean number of incidents people had been involved in over 2 weeks was just a little bit above 1. So it wasn't likely that people were involved in tons of these, but that's something else good to look for. Sure. There and then there?
You mentioned assisted living earlier on in this talk. You were saying that in assisted living, in fact, assisted living facilities where she died,
have their own room. So are you looking, given what you said about if everybody had a thing, would you predict that there would be less of this in assisted living?
There are, if you look at what limited data there are lots of good things about everybody having their own room. I mean, in general, I would go so far as to say it's not great to have people in those settings have roommates unless for some reason they desperately want to. Like a lot of them have lived in their own houses. They haven't lived with anyone else since, besides their husband or wife since they were a teen. They weren't big communal livers like some of us were. So that's very arresting and disorienting. And you have no place to escape from other people. So I think that the one thing I'm hopeful, and you raised a really good point, is because assisted living facilities vary. Does Longview have, does everybody have their own room? Yeah. Yeah, you're right. That's going to be a major structural difference in assisted living. It's not common for people to have roommates. So this whole area of roommate, altercation just isn't going to exist. Ooh, that's going to be interesting.
Well, the other thing to think about is for most people in assisted living, they have to have more capability to be in the assisted living as opposed to being.
But now, increasingly, people in assisted living fit exactly into our risk profile. Relatively healthy people with mild to moderate dementia who have the ability to get around. So, as nursing homes have become more like hospitals, assisted living facilities have become more like nursing homes. And I don't know if you folks see it, but I mean, it's you have many more people. So it was one of the justifications for this new proposal is that you really have people who seem to fit this risk profile in assisted living now. And and so maybe the environment does protect it. I think you were.
Oh yeah, correct. Misuse of psychotropic drugs is a major factor.
Yeah, and we do have for every individual involved their medication profile, and we have a geriatrician on the study who really wants to study this. So, but they're a factor in a number of different ways. One, being involved in an R-REM incident is a major trigger for being put on kind of anti-aggression psychotropic medications. If someone's doing this a lot and harming other people, in the absence of other interventions, it's a common reason why they get on them. And so that's one part of the issue. But I absolutely agree that the effects of medication, the fact that people have such polypharmacy, they're involved, they are taking so many different medications. And I hate to keep on using this as an excuse, but that is a key, that's really one of the next papers, is to look at, to what extent, the drug profiles of these people interact with this. But I think you're absolutely right.
My father had very little dementia, no psychiatry. Put on the serial pill. So he couldn't figure out why, and so he was supposed to be nursing.
Right.
It's grossly abused.
It is, and people will go to different healthcare providers. I mean, they really will have like a suitcase full of medication. You may or may not know that there is a massive movement spearheaded by the federal government to greatly reduce the use of psychotropic drugs in nursing homes, and especially for this kind of agitation, because it doesn't do any good usually. Thanks. Was there one last one? Okay. But I'm happy to stay around and chat if people have questions.
I work with the long-term care ombudsman program through the Office of Aging, and so we get to hear directly from residents, what each of them says about the other and incidents that happen all the time. And so I'm very cautious about the language of perpetrator because people end up getting blamed and therefore targeted or moved out of situations. And I think it's really difficult to sort out the dynamics in some of these situations, and whether somebody's being self-protective, and that's why, they're lashing out. So just a word.
That is, can I say that is so useful, and I forgot. But that's the other reason why we don't use that, or why we look at incidents. For exactly that at least in the whole family violence literature, violence is defined as an act with the intention of causing injury. When as many as 80% of the people you're talking about don't really have unimpaired ability to understand their own intentions. We're like, talking about the victim and the perpetrator is really difficult in these situations, and that was the second reason why we're looking at this event, prevalence, rather than experience as a victim. It's that reason, and the fact that in so many of these events, both people are sort of both on the giving and receiving end. But I still think it's worthwhile to separate those out and look if there's a situation where it really is a passive resident who's victimized by somebody else. But I think you're right, the perpetrator language may not be so great. Well, all right, well, thanks for coming, everyone.